Good evening. Welcome to Med Talk 2020. It's unfortunate that we have to be socially distanced this year, and it's going to be a little bit different format, but the good news, at least, it allows more people to be able to watch it than have ever done so before. We style Med Talks after TED Talks. We like to think that they're a good way for some of our leading researchers and clinicians to talk to you about issues in ways that the general public can understand. We're very excited for tonight's show, where three of our great people will be talking. But first, I'd like to introduce Dr. Jay Hess, Dean of the School of Medicine, for some introductory remarks.
Well, thank you, Aaron, for hosting this event tonight, and also for all that you're doing for the School of Medicine and also for Indiana University. I'm delighted that in a year when so many events have been postponed or canceled, that we're able to host another Med Talk, where we can showcase some of the most talented and dedicated people who make the IU School of Medicine such a special place. While 2020 has presented us all with numerous challenges, the three speakers we're going to hear from tonight are a reminder of the outstanding people who have been helping us meet those challenges. In short, this is a night to celebrate. Dr. Milan Radovich is one of our leading researchers working to understand how genetics shapes the way diseases develop and how individuals respond to treatment. This work has many applications, especially when it comes to improving treatments for cancer. It is part of our Precision Health Initiative, which has the ambitious aim of curing at least one cancer. Guadalupe Jimenez's inspiring story is particularly relevant right now for what it says about persistence and meeting the challenge in front of you. And while I'll let her tell her story, let me just say that she is an example of a student whose dedication to public service should make us all proud. And then finally, Dr. Robert Pascuzzi is one of our most outstanding teachers, clinicians, and researchers. He is a fine example of the people that make the IU School of Medicine Neuroscience program one of the finest in the country. And then I just want to add one last thing before our program begins. It's your gifts that enable us to do this kind of research and to attract outstanding students. Thank you so much for your support, and please enjoy the evening.
I want to thank Dean Hess for those opening remarks. I'd also like to remind everyone that you can use the Q&A feature in the application to submit questions that we will ask during our Q&A. So please feel free to do that anytime. Dr. Milan Radovich is a member of the IU Melvin and Bren Simon Comprehensive Cancer Research Center. The center is the home to the cure of testicular cancer and the world's only healthy breast tissue branch. With his research team, Dr. Radovich has been working on ways to predict how breast cancer tries to outsmart treatments, and then creating a whack-a-mole type approach that treats the cancer with one drug for the original target and another one aimed at blocking the cancer's escape pathway. Please help me welcome Dr. Radovich, and we look forward to his talk.
Good evening, Dr. Carolyn Hess. I thank you for the kind introduction. And to our friends and supporters, it's my honor today to present to you a brief snapshot on our advances at Indiana University in cancer precision medicine. In order to understand cancer precision medicine, we actually have to start at where a cancer begins. Interestingly, the journey for most cancers begin years before a patient ever feels a lump or a bump or detects an abnormality on a CT scan. It begins when just one cell in over 40 trillion in the human body goes rogue and begins to do things it was never designed to do. It goes from a cell that was designed to support human life to one that takes it. It begins to grow and divide rapidly, forming vicious tumors. It develops the ability to invade organs and metastasize, leaving lethal effects. It develops the ability to evade the immune system so that our own bodies can't get rid of it. What causes this first cell to go rogue is actually the accumulation of typos in its genetic code that we call mutations. And it's the conglomerate of these mutations that causes this normal cell to go haywire and become a lethal cancer. In precision medicine, we're focused on understanding how we can exploit these individual mutations and develop therapeutic strategies that are tailored to individual patients, where we have begun to understand that if we take a group of patients with the same diagnosis and treat them with the same drug, not everybody gets the same response. What we know is that some patients do well with a particular drug and some do not. In precision medicine, we're focused on how we use genomics and informatics and drug development to guide patients to the right therapy for their cancer. I'm proud to know, and I'm proud to let you know, that researchers at the IU School of Medicine have been at the forefront of precision medicine for many years, long before it was a buzz term, long before it was a topic you read about in the New York Times or Time magazine. First pioneered by the late David Flockhart when he was recruited to IU in 2001, creating the first precision medicine program focused on how individual genetic variability, the genetic variability that makes you and I different, influences how we respond to drugs and what side effects we experience. This program blossomed into numerous programs in cancer, cardiovascular, and neuroscience, and now is represented by the robust research programs and clinical programs we have at IU today. Through generous support from a variety of philanthropic organizations like the 100 Voices of Hope, the Vera Bradley Foundation, and the Catherine Peachy Foundation, we developed an extensive research infrastructure, bringing in technologies and know-how to advance cancer precision medicine and to make strides in this disease, first in breast cancer and then into other cancers as well. We've been able to develop numerous genomics-based clinical trials, bringing experimental, cutting-edge, exciting agents to patients whose tumors harbor specific abnormalities, matching cutting-edge drugs to individual patient tumors. We've been able to advance our understanding of pharmacogenomics, understanding how the DNA variability that you and I are born with can predict, and hopefully we can mitigate toxic side effects from these drugs. We know that patients typically sometimes fear the side effects of therapy just as much as they fear the disease. And now we're working diligently in using genomic technologies to be able to detect cancer at its earliest stages and hopefully prevent the cancers from happening, giving patients the best chance of survival from their disease. In 2014, we began to realize that this technology and know-how could not be limited to just our laboratories and to our clinical trials in downtown Indianapolis, but that we need to bring the technologies to the masses of cancer patients so that the cancer patients in all of Indiana could benefit from advances in genomic technologies, in informatics, and drug development. In 2014, my colleague Brian Schneider and I started the IU Health Precision Genomics Program, a clinical program dedicated to providing cutting-edge genomic technologies for patient care. In this program, patients are seen in specialized clinics where they're educated on genomics. Their tumors are analyzed with the most cutting-edge genomic technologies available on the planet, analyzed also with the most cutting-edge computational technologies and algorithms, and each patient is reviewed by a comprehensive molecular tumor board of over 20 IU faculty and staff who deliberate the results and determine the best therapeutic option or clinical trial for the patient. This program has seen over 5,000 patients to date, and many patients have benefited from this genomic-based therapy. But 5,000 patients obviously begins with your first patient. And I want to introduce you to the first patient that ever came through our program, Kathy Casebolt. Kathy was diagnosed with metastatic non-small cell lung cancer and came to our program after she was referred to us by Dr. Larry Einhorn on a second opinion. Kathy and her husband Brad were avid baseball fans and members of the Reds organization, and unfortunately, she had succumbed to her disease about a month after we saw her in clinic. Seen here is her celebration of life at Red Stadium, where over 1,200 people came to celebrate Kathy's life. What I'd like to show you is the results of her genomic testing, the first ever clinical cancer genome at the IU Simon Cancer Center. And what was really fascinating for her genomic results is that her tumor harbored a mutation called KRAS G12C. KRAS is a very well-known gene in cancer that promotes its development and its growth, and has represented the holy grail in oncology. For over 40 years, scientists have tried to develop drugs against KRAS to no avail. Very recently, pharmaceutical scientists actually were able to develop a very niche small molecule to this particular G12C mutation. There's no way that Kathy would have known, nor her doctors, that 4.5 years later, clinical researchers led by Dr. Bert O'Neill would dose the first patient in the world with a KRAS G12C drug at IU Simon Cancer Center. This patient, a patient from Terre Haute with lung cancer, bravely stepped up to be the first patient to receive this new agent. His tumor ended up responding to therapy. And what we've learned very recently, based on published results, is that lung cancer patients who have this very unique abnormality are responding exquisitely to this new drug. This drug is moving rapidly through clinical trials, and IU should be proud to have led the clinical development of this agent. I'd like to introduce you to another one of our patients, Dorothy Arnold. Dorothy Arnold was diagnosed with metastatic triple-negative breast cancer and came to our genomics clinic 2 years ago after several lines of chemotherapy had failed to stop her tumor growth. On genomic analysis, we had identified that her tumor had amplified a gene called PDL1. This gene is actually like a camouflage on cancer cells whose job is to tell the immune system to go away, such that the cancer literally copied this gene numerous times or amplified them to really elicit an anti-immune effect. At the time we saw Dorothy, there was a publication out of the University of California where 6 out of 9 patients with a PDL1 amplification responded to drugs that rev up the immune system. Dorothy went on to be treated with immunotherapy and has had a sustained response for over 2 years, keeping her cancer at bay with this cutting-edge agents. I'd also like to introduce you to Gwen Brack. I know many of you in the audience will be familiar with Gwen. Gwen was diagnosed with metastatic colorectal cancer at just 21 years old, at a time when most kids are just enjoying their prime of their college years. Gwen would have disease metastasize to her liver and bladder, and over a period of 8 years will endure 5 surgeries and numerous lines of chemotherapy to keep the cancer at bay. We saw her in our clinic in 2017, just after she had her last surgery, and we identified a very, very unique genomic abnormality that suggested that we could actually control the cancer with something simple as high-dose aspirin. She started high-dose aspirin in 2017 and remains cancer-free to date. Actually, at 32 years old, just a little under a year ago, she married her husband, Noah Schmidt, and currently lives in Chicago, living the life that she should. I'm proud to say that this technology and these capabilities are not limited just to downtown Indianapolis, but we've been able to distribute this across the state because we believe that all patients should have access to cutting-edge care, with clinics in Muncie, Lafayette, Bloomington, as well as a complementary pediatric program at Riley Hospital. Patients in Indiana have access to the most cutting-edge genomics and informatics available on the planet to help guide therapy for their particular cancer. I make a quip often to colleagues that farmers in rural Indiana truly have better access to genomic care than many patients who live in large metropolitan areas, seen within a week of referral. We are proud as Hoosiers that we can be able to provide this tangible product of our research at the IU School of Medicine to patients. I'll end off with talking a little bit about where we're going. And where we're going is using this genomic technology to really advance treatment in the curative setting, in the earliest stages of cancer. We recently published results in breast cancer patients that after chemotherapy and surgery, we can take a simple blood sample and detect whether cancer is still present in the body or not. If this blood sample is positive for this circulating tumor material, we know these patients are at high risk of their cancer coming back. However, if negative, those patients actually have a really high probability of doing well long term. So we've begun to design a set of clinical trials focused specifically on this very high-risk population of these women where their cancer could come back. For our first trial in triple-negative breast cancer, we've partnered with folks from Pink Forever and Red Alliance who are helping us specifically recruit women of African-American descent because we know African-American women are at much higher risk of developing triple-negative breast cancer. We've also partnered with friends at F3+R to launch a new clinical trial focused on using genomic-based therapy across tumor types for patients whose blood sample is positive for this circulating tumor material. I'll end off with saying that in addition to being able to use genomic technologies to help patients, the best part of my job is the people I get to work with. And what I showed you today is never the product of 1, 2, or 3 individuals. It truly takes a village, and to them I'm deeply indebted. With that, I thank you for your kind attention. God bless, and good night.
So Indiana University's medical school is actually the nation's largest. We have more than 1,400 medical students at any time. On top of that, we have more than 1,200 residents and fellows, plus graduate programs for master's degrees and also PhD students. Guadalupe Jimenez is an exceptional example of our students. Guadalupe completed 2 tours of duty in Iraq as a member of the United States Navy, serving with Marine units in active combat during the Iraq War from 2003 to 2008. She was often part of a team that was first on the ground to treat battlefield injuries in emergency field hospitals. After 5 years of active duty, she returned to the United States to complete her undergraduate degree in biology at Stony Brook University. In recognition of her outstanding service and leadership, Guadalupe was recently selected as a 2020 Tillman Scholar. The award is named for Pat Tillman, of course, the professional football player who enlisted in the U.S. Army following 9/11 and was subsequently killed in Afghanistan. The Tillman Scholars Program supports our nation's active duty service members, veterans, and military spouses by investing in their education and professional development. We're proud to have Guadalupe join us, be part of our community, and we're excited to hear from her this evening.
Thank you, Dr. Carroll. Good evening. Thank you all for joining us today. It is a pleasure and an honor to share with you the story of my journey to medical school. It began on a hot August day, much like this one, where my mother and father, my sister and my brother made the trip from Mexico to New York City. I made the journey as well, but I made it in my mother's womb. You see, prior to me, my mother lost a couple children, but she was determined not to lose this one. So she came to America, and with adequate health care, I was born. Since then, many things have threatened to take my life, including deployments to Iraq and Afghanistan, and most recently, a bout with COVID-19. But I'm standing before you today, alive and breathing, months away from achieving my goal of becoming a physician. After coming to America, my father worked a couple jobs to put food on the table and keep a roof over our heads, but we continued to live in poverty. Fortunately, people from the community helped us along the way. The Catholic Church provided us with clothes, public schools provided us with breakfast and lunch, and with government assistance, we always had health insurance. And my mother made sure that we never missed a medical or dental appointment. Still, my childhood had additional struggles. For one reason or another, my education always took a backseat to my social circumstances. Coming up through crowded inner-city public schools was a struggle in and of itself. They have few resources and a high student-to-teacher ratio. There was a period in time in elementary school where my family and I lived in shelters. I was transferred from one school to another and to another, and in a critical time in my education, my reading and my math foundation was interrupted. When I was 14, I started working, and all throughout high school, I worked, and at times I would even work full-time. All this to say that I never had the opportunity to completely focus on school. When I entered high school, I didn't know what I would do after I graduated. I told myself that I wanted to be a nurse, but I knew that that goal was likely unattainable. My family had little resources, we were poor, and I couldn't stop working because I had to contribute. So I went to my guidance office to discuss this, and there was a radio on next to me as I waited. That day was September 11th, 2001. I listened in as planes crashed into the World Trade Center, and later them crumbling down to the ground. That terrorist group was trying to instill fear in us, and they were trying to destroy our way of life. But I wasn't having that. And after some thought and prayer, I decided to join the United States Navy to serve with Marines as a hospital corpsman, a medic. Twice, I was deployed to Iraq, and I worked in shock trauma platoons, field hospitals, and I also worked as a CASEVAC corpsman. And it was on those deployments that I learned how to care for my patients and to connect with them in a way to let them know that I would do everything I could to save them. It was as a result of those deployments that I knew I wanted to do more in medicine. So I set a goal to become a physician's assistant. I came back and I entered community college. Friends there encouraged me to apply to a summer research program called BioPrep. That program changed the trajectory of my life. It was a challenging program, and I also discovered the world of research. There was many diverse people there, and there were also all people that were trying to achieve similar goals as mine. I fell in love with research. I transferred into a 4-year school, and I completed my requirements for my biology degree. But I knew that my job in the military wasn't done. So I enlisted into United States Navy Reserve, and I deployed to Afghanistan. When I came back, I started working with a retired Navy physician at Jacobi Medical Center, a hospital in New York City, the Bronx. I started taking care of families there, and those families reminded me of my own, and some in much worse circumstances than mine. And I knew I had to help them, and I knew I had to do more. And it was at that hospital, on those late nights, that I decided to become a physician. I started studying for my MCAT while I was working and volunteering. I looked into over 200 programs, and I came across the Masters of Science and Medical Science program here at the IU School of Medicine. That program changed the trajectory of my life. I met wonderful people there that mentored me, and I met wonderful people there that, excuse me. I started studying for my MCAT, as I mentioned, and I came across the Master of Science and Medical Science program at the IU School of Medicine. And I entered the program with the help of loans, but because I had no other financial support, it became a period in which I struggled the most financially in my adult life. I often was choosing between gas and food. More often than once, I paid rent with my credit card. I needed a job, but because of the intensity of the program and my commitment to it, I couldn't take one. In the end, the hardships were worth it. Through the MSMS program, I met wonderful people, many of whom continued mentoring me to this day. I was able to dive into the world of clinical research, which I love even more than bench work. I found a physician mentor in emergency medicine, and because of my work with him, I was published in the American Journal of Cardiology. And can I just say that I never in my life would have imagined being published in such a prestigious journal. And to this day, I continue to be amazed. After I completed the MSMS program, I entered medical school. Thanks to scholarships, I no longer have to choose between paying one necessity over another. The scholarships gave me the freedom to thrive. It was because of donors like you, I was able to focus my mental energy on becoming a healer. The scholarships helped me in 4 distinct ways. They provided me the money for my basic living expenses. They alleviated the psychological burden of not knowing how to make ends meet. It also allowed me to focus my energy on pursuing my goal of becoming a physician, an emergency medicine physician. And lastly, it allowed me time for personal growth. And as a result, I was able to give back to my community. I was able to help the uninsured population through my work in the Student Outreach Clinic. I helped the homeless community through my work with a Catholic ministry called Operation Leftover. I was also able to help the Latinx community through my policy work in the Latino Medical Student Association. And lastly, I was able to give back to my student body through my work in the Medical Student Council. None of this would be possible without people like you who have the heart to give. Yet 2020 has come with its own unique challenges. The COVID-19 pandemic changed the face of my 3rd and 4th year medical school, which moved online in March. As the pandemic intensified, many of my family members fell ill in New York City. This included my mother, my sister, a couple of my aunts, and some of my cousins. I had no other choice but to go to New York City and help them through their illness. And as a result, I fell ill myself. Fortunately, my illness was relatively mild, but my mother didn't have the same luck. As her respiratory distress worsened, I had to take care of her at home because there was just no hospital beds in New York City at that time. She and my aunts were eventually hospitalized, but fortunately, they all recovered, and that was a true miracle. Since coming to America on that hot August day, so many years ago, my family and I have overcome so much. These trials have built incredible resilience in me, and I want to pass along to everyone listening a final message. Right now, our community and our country are going through great challenges. Trials like these can be taxing, and they weigh heavy on us. I want to let everybody know that things will get better. What seems like an eternity right now is only but a fraction of our lives. The storm will pass, and the sun will shine once again. Rest assured, we will overcome this together. Thank you.
Thank you so much. That was fantastic. Our third and final speaker this evening is Dr. Robert Pascuzzi. He's the chair of the Department of Neurology at IU School of Medicine. The neurosciences are one of the school's highest priorities, and we have national expertise in Alzheimer's research, traumatic brain injury, neuroimaging, and genetic factors in neurological diseases. Dr. Pascuzzi is a national leader in research that focuses on therapeutic trials in neuromuscular diseases, including ALS, myasthenia gravis, and Lambert-Eaton syndrome. He serves as the director of the American Board of Psychiatry and Neurology and has been selected outstanding professor in neurology by the graduating medical school class at Indiana University on 26 occasions. We look forward to his talk this evening. Please help me in welcoming Dr. Robert Pascuzzi.
Thanks, Aaron. Appreciate that. Looking for my advancement tools. Hey, thanks. Appreciate it. So it's a pleasure to be here and talk for a few minutes about a couple of things. Want to talk about creeping paralysis. And so pretty be clear, what is creeping paralysis? That's the word on the street and in the hills going back 100 years for Lou Gehrig's disease, ALS, amyotrophic lateral sclerosis. So when you see somebody who has a family history from 60 years ago as someone who had creeping paralysis, that's what they're referring to. It's a horrible disease, and hopefully in the next few minutes we'll learn a little bit about it, but we'll also come away with some enthusiasm for getting to a point where we can actually treat this a whole lot better than we have been up to this point in time. And I'm also going to put in a joke, unless this gets cut out by the dean or somebody else. And it's one of the best medical jokes out there. I know we have a big audience of medical personnel, so it has to do with Count Dracula. So it goes something like this. 3 vampires walk into a bar in Carmel, and bartender thinks that's a little creepy, and the first vampire says, I want a glass of blood. And so he writes that down, the bartender does, and looks at the second vampire, says, I want a cold glass of blood. So he writes that down. And turns to the third vampire, says, how about you, pal? Third vampire says, I want a cold glass of plasma. And so bartender writes that down, scratches his head, thinks this is really weird. Look, says, okay, let me get this straight. It's going to be 2 bloods and 1 blood light. Is that okay? I think, okay, so at any rate, you can at least take that with you. But let's talk about the creeping paralysis. Disclosures, my only disclosure is I'm an IU person. Went to IU for everything except for some neurology training and been around here for many decades. So IU is my home, and that's my inherent bias. I'm going to give you a case here, and this is intended to help make people less anxious, particularly since we have an audience of clinical people. This is something that I get consulted about a couple times a month, typically by a physician. And in this case, one of my clinical colleagues called and said that since Friday, hadn't been able to sleep because the hand's twitching, it's flickering. So I said, well, can you like show it to me? So they sent me a video. And look at the hand there, you see it flickers, it twitches. The inside of the hand twitches. The little finger on the side, it twitches out. So it looks like there are twitches in between the thumb and the index finger. It's twitching a bit, and the little finger's twitching. And it turns out that when physicians see these twitches and flickers, everybody gets twitches and flickers. As long as you don't know what they are, they don't really bother you that much. You know, your eye twitches, that sort of thing. But when physicians get this, oftentimes they know too much, and they understand that muscle twitches are fasciculations. And fasciculations are something that one sees in Lou Gehrig's disease, in amyotrophic lateral sclerosis. So it's a natural fear. We just worry about these things, and so it's a reason to get checked out. The good news is, nearly always, when somebody comes in to see a physician and their chief complaint is twitches and fasciculations, it's not Lou Gehrig's disease. Lou Gehrig's patients present with other things, have other findings on exam, but it's our job as clinicians to try to make the distinction and be very clear about it. So anybody out there listening, if you get muscle twitches and flickers, particularly if you're a physician and you worry about this stuff, you should be in pretty good shape, but feel free to call me. So we actually have the patients come in, we take a look at them, we conduct a complete exam looking to establish a reason for the twitches and fasciculations. We'll come back at the very end and try to diagnose this individual. But let's talk a little bit about Lou Gehrig, the Iron Horse. I think he's a very interesting figure, not so much because of his baseball accomplishments, which were huge. So he went to Columbia. He didn't go to IU. He went to Columbia and New York and was going to be an engineer, played football, also baseball. He played in the summer league, which was not allowed then, so he got in some trouble. But then in the professional league, he had an extensive career for over a decade of hitting over 300 year after year, and his durability was incredible, became known as the Iron Horse as his nickname, until 1938, when his batting average dropped below 300 for the first time in a decade. Then earlier that year in 39, then his performance really was poor at the beginning of the season, and so he went to the Mayo Clinic to be evaluated. And they determined that he had amyotrophic lateral sclerosis. And so while we call this Lou Gehrig's disease here, most of the world calls it Charcot's disease. Charcot was the father of neurology, worked at the Salpêtrière in Paris. He trained a generation of neurologists, and he's the one that first observed this condition, and his description of it is the basis for the clinical diagnosis that's made today. So what is the disease? It's basically an adult, can be any age, more common in older people and younger people, and they typically have the gradual development of weakness, loss of function, loss of muscle in one arm or one hand. That's where it starts, on one place in the body. And it could start in a leg with a foot drop, very gradually developing. It's painless, there's no sensory loss, just a gradual decline in function. Muscle tends to shrivel up and atrophy. There are muscle fasciculations and twitches. And over time, over months to years, the weakness progresses gradually and spreads. If it starts in the left arm, it spreads to the right arm. If it starts in the left arm, it also eventually spreads down the left leg. Then it spreads up into the bulbar area. If it starts in a leg, it gradually spreads upward. In some patients, it starts in the speech and swallowing muscles. In those patients, it gradually spreads down into the neck, shoulders, arms. It's like it creeps along in the central nervous system with a regional spread. And patients tend to progress fairly steadily at a steady rate. And what limits their survival to about 2 to 5 years on average is when it spreads to involve the diaphragm muscle. If the diaphragm's not working well enough, you can't breathe well enough, that's going to limit your survival unless you go on a breathing machine like, let's say, Stephen Hawking for a number of decades. So 2 to 5 years is the typical time frame it takes for most patients to reach a point where their breathing is that critical. But for some patients, it's a more rapidly progressive downhill slope. They don't survive a year. For other patients, it's a very slow course. We have some patients that have had it for 30 years. So it's progressing, but they're just losing ground a couple % per year. Whatever slope you're on is the slope you stay on for the most part. And that's what it looks like. There are 2 different kinds of motor nerves in the brain and spine, and the 2 sets typically are both affected in this disease. So lower motor nerves go from the spinal cord straight out to the muscle and make the muscle contract. If the lower motor nerves malfunction, the muscles shrink up, atrophy, fasciculations. Upper motor neurons begin up in the thinking part of the brain. So when you want to make your arm move, you have to initiate that by triggering a signal in the upper motor nerve. And if it's in the right side of the brain, it sends a signal down a wire. The axon that goes down to the bottom of the brain crosses over to the spinal cord on the other side. It goes down the spinal cord and stops. And that upper motor nerve then hooks up with the lower motor nerve that goes out and serves the muscle. So any muscle you want to use, you have to have a hookup between the upper and lower motor nerve, like 2 electrical wires hooked up in series. If the upper motor nerves in the brain malfunction, patients have different findings on exam. They get stiff and tight, called spasticity. They get real jumpy reflexes when we tap on their reflexes. And these are features of an examination that one can see. And the neurologist's findings are typically a combination of widespread lower motor neuron findings, widespread upper motor neuron signs, and a slow progressive course over time. And yet sensation is spared, cognition is typically spared, eye movements are spared, bladder and bowel function spared. And that's the clinical presentation that leads a neurologist to say, well, this is amyotrophic lateral sclerosis. And so that description comes courtesy of Charcot. It's not a common disease in the sense of Alzheimer's or Parkinson's, but it's more common than you think. It affects 1 in 10,000 living people, so there's probably 700 patients in Indiana now. One's lifetime risk of getting it is actually about 1 in 500. It has to do with the fact that the life expectancy is limited with this disease. And it's a progressive problem and eventually becomes very difficult to manage for patients and their families, and there's pretty much nothing good about the disease. Pretty much nothing good. I think that's where we're at. So we have Charcot to thank for teaching 100 years of neurologists how to make the diagnosis. So we're at first base in the baseball metaphor. We know how to make the diagnosis. Neurologists do it. It's the neurologist's disease. And here's just a brief example of what happened to a patient, not unlike our patients. When Lou Gehrig got diagnosed at the Mayo Clinic, he went back to New York and had his famous speech at Yankee Stadium. And then he said, well, somebody has to know how to treat this. They said, well, we don't know how to fix this. And so he said, well, is there any research being done, any clinical trials? And so he found a clinical trial in New York done by Israel Wexler, a very famous, well-known neurologist at Mount Sinai who was studying the effects of vitamin E on ALS. There was a theory that this was the source of it. And so Lou Gehrig volunteered for a clinical trial. That's what our patients do here. They say, well, how do we fix this disease? And we say, well, we have a couple of things that slow down the disease a little bit, but we don't have a fix for it. And so they say, well, what's out there in the way of research so we can find something better? Patients are motivated, their families are, and they're willing to contribute to the greater good. So Lou Gehrig went into this trial. It's interesting, when he left the Mayo Clinic, he signed documents that prevented the Mayo Clinic from ever releasing his medical records for decades. But when he was in this clinical trial, this was published by Wexler. And so if you look at case number 4 of the 20 patients in the study, this is Lou Gehrig. So actually his medical record is published. LG, male age 36, man had weakness in March of 1939. And if you go through the exam, it basically describes widespread lower motor neuron signs, widespread upper motor neuron signs. This description, there's nothing else this condition can be besides ALS. What's interesting is the very bottom part, where it says treatment with vitamin E was begun in February and continued to date. The fibrillations, and that was the term then for fasciculations, have practically disappeared. Walking is improved and some power is returned in the thumbs. The case may be regarded as definitely arrested and somewhat improved. So this is science, clinical trials, published, big journal. And if you read this, you say, well, Lou Gehrig did pretty well. He was basically had his disease arrested and he's somewhat improved. And in fact, you look at the 20 patients in the study, most of them were improved. Some were recovered, marked improvement, marked improvement, marked improvement. The majority of these patients did great in this trial. And so the question then is, why is it this publication came out virtually the same week as Lou Gehrig's obituary came out? How do you reconcile that? And I think that you can. I think that, and this is a good, helpful piece of information in deciding how to conduct clinical trials and clinical research. I think the problem here is several. Number one, it's an uncontrolled study. So there's no controls. So you hear people talk about, well, do we have any controls? And patients often say, why do we have to have placebo controls? Why can't we just all get the active drug? And I understand that point of view, but if you really want to know for sure if something works or not, it's good to have controls. And then you need to have blinding, where the evaluators don't know if the patient's on the real drug or the placebo, and the patients don't know because we're all biased. The very best clinicians, it's proven, they're biased. If they know the patient's on the active drug, they want it to work, they score the patients better. Patients do the same thing. If they know they're on a placebo or active drug, they interpret their situation differently. And in this case, Wexler was a very kind doctor, had great interpersonal skills. His patients loved him. And some of them, the stories are out there, they didn't want to let him down. They didn't want to let the old man down. They knew that he's such a nice guy, this is important to him, so they would tell him they were doing better even though they weren't. And so this is, I think, a very good example of why we have to at least think through, do we have controls? Do we have blinding? Are we really sure that the results mean what in fact is reality? So we're at first base, know how to make the diagnosis. We know something about management. Got a couple of drugs that slow the disease down a little bit, not much, but a little bit. So we got some options. Management is kind of the village comment. It's no one doctor can take care of these patients. They have trouble with hands, arms, speech, swallowing, breathing. Some have trouble with cognition. And so we need a team. We need about 12 different types of professionals, and they have to work collaboratively as a team to make this a program that provides effective, comprehensive care. And so IU has a comprehensive ALS multidisciplinary clinic. It's recognized by the ALS Association nationally. And that's essential. And it's multi-departmental. It's not just neurology. So physical medicine rehabilitation, their team is in there along with us. And that's essential to give patients and their families optimal management. What we don't know for sure is what the cause is of the disease. You'd think that would be known, but it's not known except for a few important exceptions. And then we don't know how to fix it. And so that's the work that needs to be done. In terms of cause, where the cause is known really comes out of the genetic area. About 5 to 10% of these patients have a genetic form, runs in every generation of their family. This is much like Alzheimer's and Parkinson's, where 5 or 10% are genetic. The genes that cause it are known, and they can be measured. And so those particular subgroups of patients represent the group that's probably the most exciting target for treatment. So if you have an extra piece of DNA or unwanted DNA making some kind of mutant protein, it's possible to selectively construct a piece of interference RNA that'll lock up that stuff, the unwanted DNA, so it doesn't produce some unwanted protein and free up normal cell function. And that's the new wave of trying to attack each of these individual genetically based forms of ALS. And these are studies that are currently ongoing. They're starting up and making progress in patients with ALS. A couple of articles on the superoxide dismutase patients from the New England Journal of Medicine from just a couple of weeks ago, showing that there are some things you can measure in patients that suggest this could be actually working. This may actually work. Very exciting. For 25 years, since 1995, ALS clinical trials have been conducted here at IU. And these are some that go back to 95. Some of them were big multi-center national, international studies. Some were conducted just here. Some were like Telampinel was here in Hopkins. Some of them are not drug treatment trials. One involves art therapy, and we need to get some better treatments. We're willing to look at anything. And so that's the past. The present is these are the 4 clinical trials involving medical therapies that we're currently involved with at IU. And the future includes us bringing in some of these very strategic protocols for treating patients with specific underlying types of genetically based ALS, including the antisense oligonucleotides. We're doing studies to look at metabolism of patients to try to find the mechanism of their vulnerability. Is there something about the environment that makes them vulnerable to certain toxins, the exposomics? We've got some studies in neuroprotective drugs and a phase 2 study of a drug that comes from the beehives of New Zealand. The propolis that makes the beehives of New Zealand hard to destruct and hard to wear out has certain constituents that have neuroprotective properties. And here at IU, that has been studied to demonstrate benefit not only in mice, but now safety in normal healthy human volunteers and in phase 1B studies in patients with ALS, with phase 2 studies coming up. We think maybe this disease has multiple causes and has several different factors that could come into play. The same theory holds for Parkinson's disease and for Alzheimer's disease. This is the missing piece of the puzzle for the last 24 years up until a year ago. So this is Brian Perchala. He joined the faculty here in the past year, and he's the Sherry L. Sonneborn Professor in ALS Research. So for 24 years, we had a bunch of clinicians seeing patients involved with clinical trials, trying to think up ways to treat patients. But to be fair, the average clinician, the average neurologist, we're not basic scientists, and we can't be. And we need somebody who can really focus on the basic science, try to find out what's the mechanism for the disease, what are the various steps that occur to make the motor neurons fall apart and age prematurely, and how to identify the targets that would be logical to go after for therapeutic intervention. So now we have basic science here at the IU Neuroscience Center with the clinicians, and this is only the beginning now of a really new era of trying to find the actual cause or mechanisms for the disease and then get some really good options for treatment. I was just showing some of Brian's work. He's able to show nerves, the nerve-muscle interface, the muscle itself, changes in ALS patients and others, and everything from inflammation and the immune system to genetic regulation and modification in ALS motor nerves with a variety of really important insights that I think are going to make IU central to getting this disease where it's much more effectively treatable. The Sonneborns are an amazing family. Sherry was affected with this illness, and her wish was to find something that would fix it. And if not going to work for her in time, for somebody else, the next generation of people to get this. So they actually did the grunt work at working with the School of Medicine to provide the funding necessary to establish this endowed chair for Dr. Perchala. And so, like a lot of things, it's a teamwork. It's the patients, it's their family, the community, the School of Medicine, basic researchers, clinicians, everybody kind of working together to get to a point where we've got something better. All right, so here's the patient. The good news is that this doctor has fasciculations in the first dorsal interosseous muscle, that's one between the thumb and the finger, and the little finger, and so these are muscles supplied by the ulnar nerve. And so it's not uncommon if you're a hardworking person, your elbows are on the table, Your elbows are resting to irritate the ulnar nerve at the elbow, and those are the muscles that'll twitch and flicker. This patient had no weakness on exam, no reflex abnormalities, no other findings for something serious. So this was a benign form of fasciculation, which it nearly always is if the main complaint that brings someone is fasciculation. So we're not at the home plate with this disease. We're about, I'd say, second base with what's coming along. And I think the next 5 years are going to be huge at trying to get us so we're closer to getting to home. Thank you very much.
So in just a moment, we're going to be able to have questions and answers for our three guests. But first of all, let me thank each one of you for your talks tonight. Dr. Radovich, we're so fortunate to have scientists like you looking for solutions to cancer. It's your creativity and determination that you show each day that makes IU a leading cancer research center. But more importantly, you've improved the lives of countless patients who are alive because of your work. And I know that firsthand because I've met some of them. Thank you. And Guadalupe, I want to thank you for your service to our country and to the heart that you have to serve others. Your perseverance through so many challenges is a great inspiration for all of us. And you're already making us proud. And in a few months, I look forward to calling you Dr. Jimenez. And then finally, Dr. Pascuzzi, who wins every teaching award we have, and I think you can see why. But we are so grateful for your leadership in the search for a treatment for a devastating disease like ALS. Like everything you do, it's to improve the lives of patients. So thank you for your dedication. And once again, thanks to all of our donors who support the school and make the work of these exceptional individuals possible. So with that, I'm going to turn it back over to Dr. Carroll, who's going to moderate our question and answer period.
Thank you very much, Dean Hess, and thank you to all of our speakers. It's been fantastic. I do have some questions, though, that I think might just help us to continue this discussion a bit more. I'm going to start with you, Milan. So I was struck when you were talking about Kathy's story, and you talked about how after her passing, we found a drug that would work with KRAS. But you know, just as much as I imagine you might look at people's genes and say, oh, look, we can see what's in your genes and this might be a good drug for you, we might find things later that work. So how do we bank those? How do you look them up later? Do we do that? How often do we? How does it all work?
Absolutely, that's a phenomenal question. And one of the things that I know patients love to do is that we obviously use genomics to treat their cancer first, but they are just as passionate about their data being able to use to help other patients. So actually, through work through the Precision Health Initiative and in partnership with Lifomic, we've developed a world-class cloud-based database of all genomic data and medical data on our patients in a single repository. And in this database, we've been able to use advanced analytics to be able to do research to understand new biomarkers of response, help identify new clinical trials for patients, to be able to advance research in cancer predisposition. And so I think patients can really feel good about the fact that when they come through our clinic, yes, our primary goal is to help treat their cancer, but they're actually helping other patients with cancer as well through research.
And when you do these kind of studies, are we looking at sort of individual genes for specific treatments for specific diseases, or is it more we're collecting their entire genome and then we can later look for it? And do you see someday that we might just check everyone's genome for what we might need later?
I actually do envision a day that a genome sequence is something we're going to do on every person when they're born. And I think we're going to be able to better predict which disease will develop, how we can prevent those from happening. I think we're going to be able to predict ahead of time side effects that may be experienced if they were to be exposed to a particular drug and whatnot. And so the answer is really both. I mean, this data helps us really understand drugs that we can develop today and then helps us understand the etiology of diseases and advances we can make tomorrow.
Thank you. Guadalupe, your story was inspiring, but I would be lying if I didn't say there were points along the way when I was somewhat enraged almost, I would say. For someone who has given so much of their life to service, it seems you struggled an enormous amount along the way, sometimes even specifically financially, long after you'd given more than the vast majority of Americans have given to this country. What can we do better? As someone who's experienced this, what do we need to do so that others don't need to struggle in the same way that you have?
Well, I guess that's probably a complicated question, but I'll do my best. I mean, I think like in undergraduate and any like kind of post-bac program or medical school, I honestly do think the loans definitely help us, right? But because like people like myself that come from a very like impoverished background, we contribute, as I mentioned in my story, but we have to continue contributing even as we are going through our medical education, right? So our loans are not our own. You know, like I have to ration my money out because my family still needs money, right? In order not to be evicted, for example, which I did have to indeed face that challenge in medical school. But I think like something like this, like having more scholarships available and having just, I think that's like probably like, because loans, for example, they're not enough, unfortunately, but scholarships do help. In terms of like the structural kind of changes that we could make, I wouldn't I think it would have to start from a very young age, in elementary school, even middle school. There's pipeline programs that help people recognize their potential. I know that there exists some programs in New York, in Brooklyn, New York, where they identify students, they bring them up through high school and college, and they identify from a very early age that potential physicians. And then I think it's, I have the name drop, but it's like a school in Brooklyn, New York, where is Downstate University, where they take those students and kind of bring them up so they don't have to like figure out along the way, take these pauses, work, come back to school. So I think like those kind of programs really probably help the students more, because like if we have to pause, like it's going to be really hard for us to come back to our education. So I think there's a good place to start.
You talked about at one point, I think, that you were interested in becoming a physician assistant, and then later you decided to become a doctor. And I'm curious, what was the triggering factor that made you change your mind?
So my undergraduate school required us, I wanted to apply there for my post-bac, for my PA school, and they require 1,000 hours of shadowing. So I was actually shadowing PAs, and I recognized that everybody in the healthcare field holds a very important job. But I found myself kind of gravitating to physicians, and I recognized that at least the physicians that I was shadowing, they would be the ones making more of the clinical decisions. And so in order to help these families, these immigrant families, in the biggest possible way, I would have to be in that seat. I would have to have a seat in the table for me to make these calls, for me to change medicine in a way to help them. And that is truly why I entered medicine.
And finally, I'm going to ask you every fourth-year medical student's least favorite question. What do you want to do next? And then what would you like to do with your career?
So I want to become an emergency medicine physician. I think like that, I decided that during COVID. I was considering a few other fields, but I knew I wanted to be in the front lines. When COVID hit, I just wanted to be in the emergency room. I wanted to be there with my patients that I knew couldn't communicate like in English, or any immigrant family, whether it's Polish or like German, there's like Italian, there's so many in the Bronx community. So I knew I wanted to be right there with them. So I decided that I wanted to become an emergency medicine physician. I also get to be with a lot of different kind of pathology within children or adults and every walks of life. Everybody is as prone to an emergency, right? And everybody's going to go to the emergency room. So, and I like that idea of taking care of everybody. Great.
And Dr. Pascuzzi, first I wanted to ask you a question just broadly. I was struck that you talked about how when Lou Gehrig was part of these trials that they were uncontrolled and they all looked like they were working. And I was struck that Just in the news this week, we've been seeing once again where many scientists are up in arms because even today we see in times of struggle with diseases with which we have a lot of concern like COVID, there's a push for just uncontrolled trials. Just let's get treatments out there. What do you think we could do about that broadly in general? How do we do a better job of making the public understand how research needs to work?
Well, I think the public's probably not the problem. I think the focus probably ought to be on the clinicians and clinician investigators and those teams. I mean, I think they're the ones that are conducting elaborate studies and sharing those data with very bright people who understand science and then reach conclusions that are then disseminated. And I think it's fine to disseminate an opinion or an uncontrolled trial, but one really ought to emphasize, you know, we have no controls, or we're using historical controls, or these patients may not be the same. I mean, that's, in a lot of medical research, as you guys know, the criteria for evaluating a report and publishing something is pretty rigid to have that addressed. But there's a lot of stuff that's published and presented that's interesting and worth a lot more attention, but you can't take it to the bank as being truth. So I think that's the profession of medical science. I think we're the ones that need to focus on that, because otherwise, you know, if you're a very bright person and you have a degree and you're well published and you're interviewed and you tell the public that you need to take this medicine and that this is something we ought to be applying broadly, I think that's, what do you expect the public to do? I mean, they have to decide who do they believe and who do they not believe. So I think the medical profession ought to focus on trying to make sure that we do our clinical studies with a little better design. And then there are going to be cases where you may not have good controls for all sorts of reasons. And there may be a lot of cases where you don't need them. I mean, if you're treating ALS and you put people on something and 50% of them are cured and they're followed for 2 years, I mean, that's not a natural occurrence, and that would be worth a lot of points. But if you're trying to find out if something stabilizes, slows down a disease, I mean, it's very interesting but very frustrating to look at clinical trial results for treatments that a lot of us know there are treatments that work for things, but the studies we've done on them don't show it, and so we're in this awkward position. But I think it has to do with just getting better at doing clinical trials and then being a little more forthright with what do we really know from these results instead of assuming things based on some preliminary observations. What do you think? I mean, you read a lot of that
I
stuff.
don't think you're wrong. I think part of it is educating, I think, broadly all the participants in how clinical trials work. And I think it's also an acknowledgement of that placebo effect works and is real. And often, you know, you see that it's not even just that we think it works, but I think even in your talk about that patients wanted to please their physician. People often want to please or want good outcomes and don't want disappointment in all of this that's going on. And I also think that you know, it is important to understand too that there's reversion to the mean. Some people get better on their own, and we don't want to ascribe that to things that we're doing.
Right. So the placebo effect, or something that's similar, referred to as the non-specific therapeutic effect, it's important. I mean, if you have patients with a horrible disease, if you can get them 20% better, feeling better, functioning better, whether it's the hope that they have based on a new treatment strategy or the confidence they have in their physician, we want that.
Yeah.
We just don't want to see that benefit and assume it's because of something specific I'm giving them. Just realize that happens. I mean, this has been well studied for decades, the non-specific therapeutic effect, is something we need to add. You can get 20% improvement in your patients, whatever way you can get, that's worth a lot to me.
I never try to talk someone out of placebo effect. I just don't want them to think that they need to tell others that that same thing will work for them. But I had one other question for you. You showed a list of things that we've tried for years to treat ALS. I think at one point you even said something like, we'll try anything, even art therapy. We want something to work. But your excitement about new therapies coming out is palpable. And so I was hoping to just push you a little bit more and get a little bit more detail on what makes you so excited for these new therapies versus what has come before that seems to give you real optimism.
A couple of things. One is, it looks to me like ALS may be a final common pathway for a handful of different triggers, factors, stimuli that produce the disease. So in some patients, it may be post-traumatic. In some patients, it may be from a toxic exposure. In some, it may be an autoimmune process. In some, it's clearly genetic. And in some, it may be viral or post-viral, or there may be some infectious component. And I think that's a problem with trying to treat people with different types of causes with the same agent. So if you take out the people with known genetic causes, there's a lot of reason to be optimistic. So for example, I'll just cite two real quickly. So what they call superoxide dismutase, or SOD, that was the first genetic defect found a couple decades ago in ALS patients. And it's, of all the familial patients, it's about 20% of the familial cases. So this appears to be, it's interesting because it's a mutation, there are a bunch of mutations of that gene that codes for the enzyme superoxide dismutase. And so for probably 10 years, there were attempts to treat those patients with superoxide dismutase. The thought was, well, it's defective, so they must be missing normal superoxide dismutase, so that people were given oral, sub-Q, IV, intrathecal, intra-brain superoxide dismutase, and it never worked. None of it worked, and that's because it's a mutant misfolded protein that has a toxic gain of function. So the idea is to shut down that mutant protein. So there is evidence that if you use, let's say, antisense oligonucleotides that specifically target the process of trying to make that mutant SOD, that you won't make it. And there's actually evidence in mice and some in humans that published very recently in New England Journal of Medicine showing that some of the markers or biomarkers would suggest it's actually hitting its target and may actually work. If you look at the C9 repeat, which is, normally people have a couple of lines of C9 repeats normally, but in ALS and in people with dementia, some of them, they have pages and pages of extra DNA, this repeated cycle. So if you can basically try to blot out all of that extra unwanted material with a targeted antisense nucleotide to just neutralize it, it makes sense it would allow the cell to function much more normally. And so the basic science work on that looks favorable. And the current new clinical trials, the phase 1 studies, are actually providing some positive results. So, and I won't speak just for myself, I'll just speak like for the entire world of ALS investigators. If you go ask any of them, is this approach to treatment, at least in these patients, seem like it actually could work well? Or is this like the other 100 things that have been tried in 25 years where the chances are small it's going to be a home run? The field is very enthusiastic, and I personally am. And if I had a different schedule than I have now, I'd probably spend all my time working on that.
Well, enthusiasm and optimism is a good place to end. I want to thank everyone who tuned in to our Med Talk 2020. These have been 3 phenomenal speakers. Let's thank again Dr. Milan Radovich, Guadalupe Jimenez, and of course Dr. Robert Pascuzzi for their work, their contributions, future work to come. And again, to all the donors who make this possible and who make so many of the things that we're able to do at the School of Medicine possible. Thank you again for joining us.
Thank you.